Hi. Well, Norris is my married name. It's actually Garcia now. Well, almost Garcia. But you can call me Gina.
Okay. Well, Gina, what brings you in today?
Well, it's a little personal. My no has been kind of itchy and kind of painful lately. I'm sorry to be so forward about this. It's really been bothering me. I think it was something my ex-husband gave me. You know, he used to be a Texas Ranger.
Okay, well, I'm sure we'll have time for that story later. But for now, first tell me, when did the itching and pain start?
Well, as you can probably tell, I'm getting up there in age a little bit, so probably when I turn about 60.
Okay, anything else been going on I should know about?
Well, you mean other than it being drier than Africa down there? I guess, you know, but I guess that's common with age. You know, now that you mention it, for years, ever since I went through the big N, yeah, I think that's what they call it. Ever since I had that, I've had these occasional bleeding episodes, not like when I used to have my period, but just kind of leaky, bloody stuff.
Okay, anything else?
Well, you know, it's, again, ladies aren't supposed to talk about this, but I also have this disease that I got from my multiple sex partners. I think they call it the clap. Yeah, that's what it is. I used to get these warts down there. It was really disgusting.
Okay, well that's helpful. That was probably HPV. But tell me, how long has the pain and itching been going on?
You know, I'm not sure. Probably years now, but it's been getting progressively worse. In fact, it's gotten so uncomfortable that I don't spend any, you know, private time with my husband anymore. It just hurts too bad.
Okay, well have you seen anyone else for this ever?
No, you know, I saw some guy for that HPV thing. He was just some radiologist neighbor of mine, John something or other. He just told me this big story about how he knew the fellow who invented it or something like that.
Okay, so you don't see a doctor regularly then?
No, I mean, occasionally I have one of them lady exams, but I've never mentioned this problem before.
Okay, any other health conditions, chronic diseases you should know about?
Well, I also have the diabetes. And the doctors always ask, so I'll just tell you now, I smoke a lot. And I'm not going to quit, so don't ask. And I've also lost quite a bit of weight over the last couple of years, but I'm not going to complain about that because I didn't even have to go on a diet.
Well, I've got your form here, and it looks like you filled out all of our questions, and I've got all of your history. So unless there's anything else, I'm going to just go ahead and step out for a moment and let you get into a gown, and then I'll be right back in for your exam. All right, so the risk factors of vulvovaginal cancer is multiple sex partners like Miss Gina had, HPV, again, like what she had. Becca's going to talk a little bit more about the differentiated VIN3 and VIN2. A previous cervical intraepithelial neoplasm, cervical cancer, again, smoking like Miss Gina, immunocompromised diabetes like her, and Paget's disease. Demographics of these people affected is going to be very rare. As you can tell from these statistics, vulvar and vaginal is very rare. And typically they're postmenopausal women, again, like Gina was. The common signs and symptoms for this cancer is going to be the most common one is pruritus, which is exactly what she came in complaining of. Pain, and then also pain with sex. She's going to also have vulvar discharge or bleeding. And then the lesions, as you can see, can be localized, isolated, they're raised, white or red. They can also have like a warty or papular or ulcerated type lesion. Are you all ready?
Yes. Come on.
Okay.
Sure, no problem. Is this going to hurt? What are y'all going to do?
I'm just going to take a look and make sure that I don't see anything abnormal. And it shouldn't be uncomfortable, but if at any point you are, you can just let me know.
Okay, just a quick question I just have to ask. Would it be okay if my husband comes in for this part? You know, he's much better at the anatomy part than I am.
Sure.
excited to be here. This is such an honor. I just love having here for my whole life.
This is my husband, Todd.
Really point stuff out and tell Kate, it just helps me. Really visualize everything.
Okay, why don't you just go ahead and get comfortable here?
I see you get
I'm sorry if my vagina's riding a little high today.
I'm just going to go ahead and get started. I'm just going to first just kind of be
just like the
inspecting. Yes, just like the diagram. So I'm just going to take a look, and then I'm going to do I'm going to do a spectrum exam, and then I'm going to do a bimanual exam. Do you have any questions?
Yeah, what's this this cauliflower looking thing right
Oh,
there?
wow, I know exactly. That's on the way in the door.
Well, you know, that's probably something that we should biopsy today. But I'm just going to go ahead and take a look inside real fast with, if you could just grab my colposcopy stars. So I'm just going to take a look inside here. And it looks like I'm seeing a black ulcerated lesion in there that we should probably. I'm just going to go ahead and try to take a biopsy of that. So we'll just take that. Shouldn't feel any pain here, just a little pressure. Okay, now I'm going to just go take a biopsy of this one too here. Okay, thank you. Alright, I'll send those in. Alright, so I think we're going to be done with the exam portion.
Alright, so y'all done?
Yes, so we've collected a couple of samples. And so we're done for today, but I'm going to have to send those off for analysis. So I'll just give you a call, and you're welcome to come back as soon as I have the results on that, okay? All right.
So the pathophysiology of this cancer. It's a little bit different, but pretty similar for the vulvar and vaginal. 90%, so almost all, are squamous cell carcinoma, with a very small percentage, 2% is melanoma, and the remainder are carcinoma, sarcoma, basal cell, or adenocarcinoma. And then from there, it's localized, and then there's a predictable spread from the regional lymph nodes, starting in the inguinal and femoral first. And then vaginal is actually not usually a primary cancer. Usually when someone has vaginal cancer, it's spread from cancer of the cervix or vulvar. So that may be why it's a little bit more common. How you diagnose, as you saw, was colposcopy. You want a wedge or punch biopsy in multiple different areas to make sure that you have a good sample. And then this can be performed in office at the GYN with local anesthesia. And then you send them off to histology. And in terms of grading, this is kind of similar to how we did the cervical cancer. So this is the vulvar intraepithelial neoplasm, 1 to 4, or to 3. And there's a bunch of different classification systems. So there's the World Health Organization is the first column. And that's broken down into mild dysplasia, moderate, severe dysplasia, and simplex type. And then in the clinical or Bethesda system, there's just high grade and low grade. And then the differentiated type is a little bit different. That's what Janice was talking about. It's not HPV related, and it can lead to squamous cell carcinoma and Lynchian sclerosis. The first one, then one, is a cancer precursor, whereas the other ones, if not treated right away, can lead to a cancer. And then once it is actually cancer, this is the staging system. And so it's 0 would be in situ, 1 is still confined to the area, just in the vulva, and is less than 2 centimeters. The difference with 1 to 2 would be that it is now greater than 2 centimeters, but it's still confined. And then in 3, it's now invaded into areas close by, like the urethra, anus, vagina, or regional lymph nodes. And this can be of any size. And then stage 4 would be spread to distal metastasis. And then there's a little bit different system for the vaginal intraepithelial neoplasms. So again, these are may or may not be cancerous, but first is the basal epithelium is involved, then 2/3 of the vaginal epithelium, followed by the third classification is that most of the epithelium is involved. And then very similar system between the two different types of cancer in terms of staging. Welcome back, Gina and Todd. Hi, so you've been along again as well.
Yeah, sorry about that. You know, he is fascinated by the weirdest things. But, you know, I like to have him here for support.
Well, I'm glad you're here. So we got your results back, and first of all, the biopsy we took during the colposcopy exam that was from inside of your vagina came back a melanoma.
Wait, you mean I have skin cancer in my vagina?
Oh, honey. Actually, a melanoma refers to an abnormal growth of the pigment-producing cells of the body. It is usually associated with skin cancer, but it can occur oftentimes in other places. So if you turn just to place 356,
Exactly right. It's not the most common form of cancer in the vagina. The most common form is actually adenocarcinoma, but generally those are seen in younger patients, and those are endometrial or gland abnormalities.
So why do you think I have the melanoma?
Well, like I said before, you know, when I was doing the exam, I saw a dark spot inside of your vagina, and since moles, or as we refer to them as nevi, usually don't occur inside the vagina, so anytime we see one, we always take a biopsy of it.
That's the top. That's enough top. Is that all you found?
No, actually, so that other lesion that we found did come back a squamous cell carcinoma. And that one was the one that was in your vulva.
Wait, now it's in my mouth?
No, I think you meant uvula. So same letters.
the vulva is the female part of the genitalia. It consists of.
That's enough talk. You know, I've had just about enough meat
So back to the results. That, like I said, that cauliflower-looking lesion did come back as squamous cell carcinoma.
Wait, more cancer?
I'm afraid so. It's actually squamous cell carcinoma is the most common form of vulval cancer.
Well, what does that mean for me?
Alright, so as far as vulvar cancer treatment, the goal of treatment is to basically completely remove the lesion. First line treatment is always going to be surgical, and then you'll have a wide local excision or laser ablation. The non-surgical is going to include the chemotherapy, which includes the 5-fluorouracil plus the cisplatin, and also radiation. For the vaginal cancer, it's going to be a little bit different. So the goal of treatment is to completely remove the lesion and restore sexual function. So the first line, instead of being surgery, is going to be radiation. And then you can still have the surgical with a laser ablation or local excision. And especially if it's a higher grade, like a grade 4, then you will have a radical hysterectomy or an upper vaginectomy plus a pelvic lymphadenectomy. And then non-surgical, you can still add the 5-fluorouracil. And as far as prognosis, you have we can do the 5-year survival. And then for the vulvar, it's going to be really good for stage 1 and stage 2. It's going to be 60 to 80%. Stage 3 is going to lower down to 45%, and stage 4 will drop down to 15%. And then for the vaginal, you have the squamous cell carcinoma, and that'll be about 42%. And then the adenocarcinoma will be 78%. And then our sources are at the bottom. So we use First Consult, MD Consult, the iPad app, and then the Obstetrics and Gynecology 6th edition book.
You know, Gina, squamous cell usually begins as raised, flat, hypertrophic areas of the skin that.
You know what, Todd? I think we need to take a break. You know, this has been a really stressful day for me, and all you can do is talk about pinning and palpating things.
Well, that's fascinating. And fine, why don't you just fly down to Texas and be with your precious Chuck? I hear his tears can cure cancer.
Well, you know, that may be true, but if it is, it's too bad. Because unlike you, Todd, Chuck Norris has never cried.